move on to the next session, which is donor workup. And to cover that, I would like to invite Dr. Piyush Varshney, who is now an associate professor of surgical gastroenterology at AIIMS Jodhpur. And to chair this session, we have one of the stalwarts of SGPGI alumni, Dr. Sadiq Sikora, who was to begin with a senior resident, but then went on to become one of the senior consultants there, and who's now at Sakra Hospital in Bangalore. Most of you in India would know him, that he is a leading authority on safe cholecystectomy, bile duct injury, pancreatic surgery, and so many other things. One of the best teachers in the country, who's respected a lot by his former students. And the lead questionnaire for the session will be Dr. Ajit Mishra, who's at DKS Postgraduate Institute in Jaipur. He also holds the additional charge of being the Deputy Director of the SOTO of the state of Chandigarh. So over to Sadiq, please.
Thank you, Dr. Kapoor. First and foremost, I must say that, from your quiver, this is another arrow which has come out. You've been a pioneer in medical education, which is obvious by the popularity of JST and JSF. And I won't congratulate you, but I would say that we should just sit back and admire your commitment to medical education. So thank you very much for bringing this on this forum. Now on to the topic of LDLT. I mean, it's such a challenging technical and surgical exercise that it sort of transcends a lot of boundaries, and we need to discuss all of this, and maybe this forum would address some of these. Why LDLT has become so common? I mean, in Asia, Southeast Asia, Far East, is primarily because we do not have a disease donor program. And adversity is the mother of invention. And people or surgeons in this area develop these skills to master living donor liver transplant. Nevertheless, the ethical consideration of living donor transplant is against the basic principle of to do no harm. And here you are taking a normal individual and subjecting them to a major surgical procedure. So the fiduciary responsibility on the physician is onerous in terms of safety for the donor. And I think how much to work up and how to ensure the safety of the donor would perhaps be covered by this donor evaluation for LDLT. I think most people know that some programs in the beginning, especially in the US, stopped because of donor mortality. Of course, we have come a long way since then, and we have mastered the donor surgery now. But nevertheless, the evaluation is very critical in selecting the donor. And I would therefore invite Dr. Piyush to present the donor evaluation to ensure that there is a safe selection of donor for a good outcome of donor surgery. Dr. Piyush, please.
Thank you very much, sir. Am I audible, sir?
Yes, yes.
Thank you, sir. First of all, thank you to Kapoor, sir, for giving me this opportunity. And as rightly said by Sadiq sir, that donor evaluation is of the primary importance for any established or establishing a living donor transplant program. So donor safety is the key for a good outcome. For obtaining a best quality graft for the recipient is the primary responsibility, keeping in mind the donor safety as well. It has to be primarily voluntary. And we should keep in mind that it has his underlying mortality as well as morbidity to the tune of around 10%. So what is an ideal donor? Ideal donor, age below 40 years, there should be no steatosis or any underlying chronic liver disease or lesion. There should be no transmissible disease. Anatomy should be favorable. Volume should be adequate, and patient should be psychologically stable. But if we see a real life scenario, hardly 50% of the donors qualify these criteria. So donor evaluation is more or less a standard with some minor differences as per the center's policy. So this is what we follow at AIIMS Jodhpur from our Mentor Institute ILBS. So it is a 4-step evaluation. Step 1 consists of consultation, risk explanation, and thorough history and examination, along with some basic blood investigations, viral screening, and preliminary imaging such as ultrasound and NCT abdomen for liver attenuation index. Step 2 consists of imaging for anatomy and volumetry with the CCT and MRCP, as well as consultation with the chief surgeon so that the donor knows what he's going to undergo in the near future. Step 3 is just to obtain fitness regarding to other systems and special tumor markers in some special circumstances that I will cover in subsequent slides. And the final step is the consultation with the surgical team authorized by the ethics committee. And depending upon the center's policy, a video consent or informed consent is a must. So I have just divided into 2 parts. First is the general consideration, and second is the anatomical consideration that are important for selecting the type of the graft. So considering the time limit, I will just cover the general considerations with some real life scenarios and examples. And first of all, the thorough history is important to know the age, any comorbidities, any prior history of jaundice or liver disease, any previous surgery, family history, and substance abuse history. I will come on to this one by one. So as we all know, this data is extrapolated from DDLT. As the age of the donor increases, there is increased chance of stenosis and as well as increased susceptibility to ischemia reperfusion injury. So the same holds true for the living donor as well. So as the donor age advances, there is a chance of increased steatosis. So taking on this example, a 54-year-old ophthalmologist, a qualified doctor with a BMI of 25, with no comorbidities and a good performance status. So it depends upon the center to center, but if the donor is well qualified and understand the risk, these donors can be qualified for a safe donation. Next, coming on to the comorbidities, hypertension, ideally the donor should be free from all comorbidities. Hypertension, if controlled on single medicines, can be taken up. Diabetes mellitus, usually the donors are rejected upfront. Hypothyroid should be controlled. If any evidence of active tuberculosis, the donors are rejected. And evidence of old pulmonary tuberculosis, depending upon the pulmonary function test and advice of a pulmonary physician, these patients can be further worked up for liver donation. So this is an example of 48-year-old lady who had apart from fasting blood sugar of 106 and HbA1c of 6.4. So what we do is, this is a pre-diabetic state. So rightly rejecting the donor upfront, these donors can be sent to a dietitian and endocrinologist for further workup, and other functions like performance status, volumes, and liver biopsy are normal. Then these donors can be further evaluated for donation after proper weight loss. So another issue is mental retardation. So mental retardation or low IQ is generally not is considered as a contraindication, but then it should be subjectively and objectively analyzed. With we have a lot of batteries and scores to quantify the mental retardation and the ability of the donor to understand the risk of surgery. So these are better evaluated by a psychiatrist and then further proceeded accordingly. Next is the previous surgeries. So what all surgeries do are contraindications for a safe liver donation. So if we come on to low abdominal surgeries like LSCS or hysterectomy, these are usually not under contraindications if the donor has a smooth post-operative course. Laparoscopic cholecystectomy, yes, of course. Nowadays, many donors come with the past history of laparoscopic cholecystectomy. These donors can be safely worked up for liver donation, provided the biliary anatomy is favorable and we do not anticipate repeated cholangiograms intraoperatively. Open cholecystectomy, usually donors are not taken up because they have quite adhesions in the upper abdomen. So these donors are usually rejected. And like heart surgery or other systemic evaluation, if the donor is fit enough after and not on any medications like with ASD closure device, these donors can be safely worked up for further evaluation. Coming on to some hypercoagulable state and genetic diseases like Budd-Chiari syndrome. So these patients usually have genetic disease or inherent with them. This patient, for example, had Leiden-5 mutation, which on the background of a CLD that required transplant. So all 5 brothers were potential donors, but eventually on workup, all were found to have Leiden-5 mutations. So finally, ABN compatible liver transplant was done. So important is that family history should be taken up thoroughly. In cases of Wilson disease, the siblings should be tested. In Budd-Chiari syndrome, the donor should be evaluated for a hypercoagulable state. And in case of autoimmune etiology, the donors should undergo these tests like ANA, AMA, anti-LKM1 and IgG. Coming on to the abuse or history, alcohol and smoking, active abuse is usually a contraindications. Drug use, proper history should be taken up, like especially drugs like valproate and lithium are hepatotoxic. So proper history should be taken. And if the patient has prior history of steroids, then these patients are usually rejected. Donors are usually rejected. Coming on to the examination, the BMI, performance status, vitals, and system examinations, all are important. This lady of the BMI of 32 kg per meter square. So ideal BMI should be 18 to 28. If the donor is having a BMI of less than 18, they are usually rejected and advised to have weight gain. Between 28 to 30, weight reduction, diet and exercise are advised. More than 30, these donors are usually upfront rejected and accepted only after proper weight reduction, and may require liver biopsy to quantify steatosis. So this lady for donor for husband for ethanol blood group A positive. So usually blood group matching is done, but just to highlight that ABO incompatible liver transplant can be done at specially with equivalent results. So this is also an option, but usually a blood group compatible transplant should be offered upfront. Coming on to the modifiable factors, suppose the patient is having low hemoglobin or a high hemoglobin. So these patients should be further worked up for correctable causes, such as in females, they should be worked up for iron deficiency anemia or vitamin B12 deficiency anemia, stool for occult blood and menstrual loss. Proper history should be taken. And the causes of high hemoglobin, such as smoking or high altitude, should be ruled out. And of course, hematology, JST mutation should be tested. And if there is a platelet count is low, then before rejecting the donor, these counts can be checked manually. Sometimes there can be error and found to be normal. So if there is some correctable cause, then these causes can be corrected, and then these donors can undergo donation safely after correcting these causes. But sometimes these uncorrectable causes are found, so these have to be rejected. Coming on to the deranged liver function test. So deranged liver function test, they can be either indirect hyperbilirubinemia in a normal donor, or enzymes can be high. So coming on to the hyperbilirubinemia, there can be two major causes like G6PD deficiency and a Gilbert syndrome. And enzyme may be high due to history of alcohol or non-alcoholic steatohepatitis. And these patients are usually advised or weight loss and further evaluated with a liver biopsy. So this boy was evaluated with G6PD as well as starting found to have homozygous repeats for TS7. So he was advised weight reduction and dietary modification. And after 1 month, these LFTs were all similar. So he underwent liver donation safely. So the point to highlight is that not G6PD deficiency above WHO class 2 and these Gilbert syndrome, these are contraindication nowadays, provided that liver function tests are normal and other parameters are within safe limit. Coming on to the viral markers, if any of the viral markers such as surface antigen, anti-HCV and HIV is positive, these donors are rejected. Anti-HB core is another topic. So the detailed history has to be taken, and in certain circumstances, these donors can be accepted provided that the recipient has to be long-term lamivudine or other antivirals in the post-operative period. Coming on to the NCCT, liver attenuation index, that is the ratio of liver to the spleen, has to be in the range of +5 to 15. If it is less than -10, that indicates the steatosis is usually more than 30%, and these donors are usually rejected. If in the range of -10 to +5, these donors can be worked up with further dietary modifications, exercise, and a repeat LAI in a liver biopsy to check if they can be proceed to further safely donation. Abnormal liver biopsy has specific indications such as abnormal liver function test, high negative LAI, individuals with BMI more than 28 or 30 who are on a weight loss program, age, genetic relationship to a patient with autoimmune or a genetic liver disease, and a core positive serology. Usually on biopsy, if there is more than 30% steatosis, these are rejected. Less than 10% are safely accepted. And more than 10%, these patients can be further worked up if they are able to maintain on dietary modification exercise. So this lady, for the donor for her husband, lost weight around 5 kg, and the biopsy was showed the decrease in the grade of steatohepatitis. So underwent a living donation uneventfully. Finally, coming on to the volumetry and the volumetric features. So just to touch upon this, that the 30% FLR is the standard FLR that is recommended, and they have, the volumetry can be done. We have sophisticated softwares nowadays, such as Myrian, to calculate the volumetry and to select the type of graft. I will not touch upon the volume anatomy considerations as well as the biliary anatomy due to the lack of time. But I will just highlight that the selection and outcome of potential liver donor, this study from ILBS shows that the stepwise process is crucial, because if we see out of 460 donors in this study, 204 were rejected upfront in step 1 and step 2 itself. So we should not forget that apart from the financial constraints, these donors also carry with them the social and emotional burden. So if we can reject them early, then another donor can be worked up timely, and a lot of manpower as well as finances can be saved in this process. So we should keep in mind that it is there are some complications such as contrast-induced nephropathy, anaphylaxis, and liver biopsy may lead to severe complications such as bleeding, hemophilia, and AV fistulas. So although incidence is low but definite, so these has to be kept in mind, and donor has to be informed. Finally, after thorough and vigorous evaluation, there are chances that the donor procedure or the operation may have to be abandoned. So this is the paper again from ILBS that shown that in 307 donors, 7 were aborted due to various reasons such as unexpected biliary pathology, parenchymal abnormalities such as fibrosis, and hemodynamic instability. So it is a real possibility, and we should keep in mind, and the donor should be informed about this possibility as well. Finally, I would summarize that meticulous donor evaluation is most important aspect of our living donor liver transplant program. Donor morbidity and mortality are not excusable given the current standard of medical care. Serious donor morbidity and mortality will have a major impact on the program and also will lead to the loss of trust of the community on the transplant surgeons. Any center that is embarking on a living donor liver transplant program should establish a protocol and adhere to it. Obviously, the donor will suffer from a donor operation. She should not have additional trauma and suffering due to negligence during the evaluation. I would suggest postgraduates to go through this paper of 19,000 living donor survey, so that you can know that what are the selection policies at the major transplant centers across the globe, not only in India but across the globe. The major transplant centers, what do they follow in selecting their donors? Thank you very much.
Sadiq. Ajit, you can come in. Yeah.
Thank you, Piyush. Thank you for covering this quite in a succinct and deep, but also giving all the information. So I'll ask Ajit, since he's the leading question maker at this forum. So can you please come up with your queries and discussion?
Ajit, come.
Yes, sir. Thank you, sir. Good evening, sir. First of all, thank you very much for giving us the opportunity. Piyush, you have done a very excellent job in putting up the summary regarding donor evaluation. A few questions regarding that. You rightly mentioned that the ideal donor, to get an ideal donor is very difficult. So there are scenarios, sometimes we get the only one donor, which is either a wife or a brother who is obese. But the BMI may be like 30, 32, but the LAI on CT is plus 16 or plus 14. In this scenario, how do you go forward? Like, do you do a fibroscan or do you do a liver biopsy in spite of giving?
So yes, obviously obese or BMI is a cutoff for taking a patient for living donation. So as I mentioned in my slides also, that BMI above 30 is usually a contraindication. If a patient can achieve a BMI of less than 28, then these patients, provided that other like liver function tests are normal, and the LAI you said that is plus 16. So if there is a doubt, we can go for a liver biopsy, and if liver biopsy is a confirmatory for steatohepatitis, then these patients can be safely taken for liver donation.
Any role for fibroscan? Because even liver biopsy has a set side. It may not be the representative. It can be just one section. So do you consider fibroscan in such patient? And the same question posted in the chat box also, that any cutoff the fibroscan beyond which the liver is rejected.
Yeah, definitely. Fibroscan is also a non-invasive modality to predict the fibrosis in donor. So fibroscan can be used, and the values of median attenuation parameter above 8 are usually rejected. And if they are less than 8, so finally, to confirm that the steatohepatitis is less than 10%, the biopsy is needed. So, but yes, fibroscan can be used as a tool so that we do not have multiple liver biopsies. The patient, if having a high fibroscan, can be advised the weight loss program, and then if he attains a subsequent weight loss, then finally a liver biopsy can be done if the fibroscan normalizes.
The other problem what I have faced in practical scenario is that after a significant weight loss, the liver volume also shrinks. Do you have faced something like that after a significant weight loss of 20 kg, the volume has decreased? So do you accept such liver? Because they are saying that after a weight loss, also there is some amount of fibrosis going on in the liver also.
So in my short experience, I have not seen like any donor losing 20 kgs. So yeah, I have
Okay.
seen donors losing 5 to 10 kgs. In that, I have not seen that the liver volume has changed drastically. So I have not seen any donor losing 20 kgs in my short experience. So maybe
Okay.
senior persons can answer.
Okay. So there are some questions in the chat box. So fibroscan you have already
Please
answered.
take them.
Yes, sir.
I'm saying, Piyush, please take the questions from the chat.
Yes, sir. So the role of fibroscan has already been discussed. Any cutoff in fibroscan, usually above 8, is taken as a cutoff. How do we decide MHV to be taken or left with a graft in donor? So yes, I have not touched upon the anatomical considerations. So if we are taking modified right lobe graft, then it has to be left with the donor. And if we are taking a left lobe graft, then obviously it has to be taken with the graft. So this in itself is a big topic. So yes, the MHV is a key in deciding and selecting the type of the graft. HLA was written in step 4 of your list.
Dr. Yasir is from Pakistan Kidney and Liver Institute, so he has put up this question. Please take.
So yes, HLA, we usually as a normal protocol, HLA is not advised, but yes, if there is a high index of consanguineous marriages, or there is HLA usually nowadays done in major high volume centers. If there is a full match or a one-way match, there is a high chance of a graft versus host disease in the post-operative period. So usually a full match is not accepted for liver. Those centers who are regularly doing HLA, keep these things in mind. What is the implication of CMV, IgG, MG positive in workup? So the antiviral prophylaxis has to be continued in the post-operative period, depending upon the quantitative DNA rather than the CMV, IgG, or IgM positivity. The lymphocyte cross match doesn't usually not done. Beyond what cutoff on liver minus spleen index is biopsy indicated? As I mentioned, that LAI less than minus 10. The patient is advised weight loss. Is there any place for compromised grafts, that is graft from HIV, HCV, HBV patients with any riders, or is it an absolute no? So if the surface antigen is positive or HIV and HCV is positive, then usually these donors are upfront rejected.
Sadiq.
Yeah, thank you, Piyush. Piyush, a couple of things I also wanted clarification. You said age 40 in your first slide, but I think most people would accept about 50, and you showed some examples of how even elderly or post 50 can also be accepted, provided other things are in order. Am I right?
Yes, sir, absolutely. So as I already mentioned, that the ideal donors are like, if we do real life scenarios or practical scenarios, we found that less than 50% of the time there will be all the criteria will be fulfilled in ideal donor. So obviously we find certain scenarios where the donors are age more than 40 or maybe above 50. So if you look at the high volume centers now, the patients more than 50 are also being taken up, provided they understand the implications of the surgery, what they are going to undergo.
The other thing which sort of struck me was about mentally challenged individuals. And you said that they could be donors. Isn't it a little difficult scenario to assess that how and to what extent, if they are mentally challenged, that you would accept them as donors?
Yeah, that's absolutely right, sir. I agree with you. Obviously, so sir, this labeling the patient as a mentally challenged or a low IQ is very difficult task. So I actually already mentioned that there are many scores and batteries, and they are rightly evaluated by a psychiatrist. So if they can understand what this surgery can they are going to undergo, and a psychiatrist give them a green signal, then obviously rather than rejecting them, and if there is no other options in the family, so these donors can be worked up as a potential donor. No, I'm not saying that these donors are always taken up for workup for donation, but in special circumstances, they can be worked up with psychiatrists giving a green signal.
And one final comment I have is, in our setups or in context of India, there is you have to pay attention to the socio-cultural, environment. And a lot of what is voluntary may not really be voluntary. So how do you, in your practice, make sure that it is actually a voluntary donation and not in some form of a coercion or in some manner, a subtle coercion because of the family dynamics?
You're right, sir. Especially in the Indian circumstances, this is quite possible. But yes, a thorough counseling session with the donor individually is important. With the chief transplant surgeon is also important. Now, obviously, certain things are beyond, and these has to be looked upon by the institutional ethics committee. So, yes, if the surgeon feels that there is some certain gray areas are there,
Hesitation.
upfront rejected by the chief transplant surgeon.
So maybe, individual, isolated sort of discussion with the donor in a private, ensuring that their hesitations or reservations would not be revealed to the family, and having a personalized discussion is also a good measure to assess how voluntary and how confident they are to be a donor. Sometimes they are afraid still, but they want to help out. So I think those things are. So I think you've covered a lot of these things, and it's highlighted the fact that they do need an extensive workup to ensure. And of course, you couldn't cover the anatomical part, which is also very important and significant, especially in developing programs versus experienced programs, because what would be rejected by a developing program may still be acceptable by a experienced program. So thank you very much. And I hand it over to Dr. Kapoor.
Thank you, Dr. Sadiq, Piyush, and Ajit. Thank you very much. I think there was one more question which probably we missed. That do you recommend us a brain scan for looking at an unsuspected aneurysm? I think I saw that question. Could you please take that?
Brain cancer. Usually, if the patient is asymptomatic, no history, prior history of any stroke or unconsciousness, there is no. The brain scan is usually not done in a donor.
Okay. Thank you, Piyush. Thank you, Ajit. Thank you, Dr. Sadiq.